Good morning to those joining us in Asia, and a very good evening to our friends joining us from Europe and America. I'm Jack Tay from the Singapore General Hospital. Welcome to the second session of Tumor Boards in Focal Therapy, organized by the Focal Therapy Society. We have a poll coming up to ask you guys, how much focal therapy are you doing in your current practice? So if you could help answer that poll, we'll be able to try to tailor the session better to you. Focal therapy is a highly personalized intervention with the aim of treating the aggressive cancer while sparing as much of the normal non-malignant tissue as possible in order to minimize side effects and maintain quality of life. The cornerstone of success depends on identifying suitable patients for treatment, as well as close surveillance in order to treat any new lesions or recurrences early should they occur. Tumor Boards in Focal Therapy is a quarterly webinar to help practitioners better select patients and choose salvage therapies through a tumor board style case discussion with commentary by an international panel of experts. I am very happy to be joined today by our esteemed panel comprising Dr. John Feller, radiologist and Chief Medical Officer at Halo Diagnostics, Dr. Arvin George, Assistant Professor in Urology from the University of Michigan, Dr. Herbert Lepor, Chief Urologist at the New York University Langone, and the Martin Spatz Chairman of the Department of Urology at NYU, Dr. James Wysock, Assistant Professor of Urology at the New York University School of Medicine and Chief of Urology Service at the Bellevue Hospital, and Dr. Samuel Yee, Consultant Urologist at the Prince of Wales Hospital and Clinical Associate Professor at the Chinese University of Hong Kong. Today, we have an exciting lineup of 4 cases, each followed by our panel discussion. For the audience, please input your comments or questions into the chat, and if time permits, I will direct these to our panel. Without further ado, I will hand over the control to our first presenter, Dr. Arvin George. Arvin, please.
Great, thank you, Jack, and thank you for the invitation and to the panel. I'm actually hoping to get some clinical input on this case, so look forward to hearing the thoughts from the panel. Okay, so this is a 74-year-old gentleman with initially with an elevated PSA. Here you can see his kind of trend before he arrived to see us. PSA essentially went up to relatively quickly in 2017 to about 10. He had good baseline sexual function, excellent urinary function, and actually had an MRI which demonstrated a PIRADS4 lesion in a midline location, which can sometimes be challenging. Here you can see the location of the lesion here on T2, axial and sagittal, and then similarly here you can see it on our DWI and our DCE as well. Really isolated to that one location. The patient underwent a biopsy. That biopsy showed 4 cores that were positive. Only the target was positive. There was grade group 3, up to 80% involvement of the core, and there was some tertiary pattern 5, which in my own experience has been really a little bit higher risk than I feel comfortable treating with ablation. However, he was newly married with a younger partner, refused any other therapy and wanted to maintain potency, and that was very important to him, so much so that he mentioned that he would not want to pursue any treatment. Otherwise, he would just pursue surveillance or watchful waiting. So after kind of careful discussion in multidisciplinary clinic, patient was enrolled on a PSMA PET trial as well as part of staging, which was essentially negative. Outside of the prostate, we proceeded with a fusion guided cryoablation. And here, this is one of the initial cases that I started to perform, and I was doing early imaging, predominantly to help gauge the actual ablation of the intended focal zone. Here you can see a 2-week MRI post-ablation. I no longer do that, really push that out to 6 months now. And here you can see on T2 imaging, you can't tell that much. You just see some, you can just see some disruption of the prostate. However, on DWI, you see something similar, but on DCE, that's really where we can see the good bilobal ablation, as there were cryoprobes placed on either side of the lesion with coalescence of the ice ball in the midline. This is the patient's PSA trend. He actually did really well for a number of years, about 3 years, and almost exactly 3 years, his PSA started to rise again. He had a repeat MRI. Here you can see on DCE there's some persistent enhancement in the midline apical area. Biopsy showed we took multiple cores and mapped out that entire area. However, only one core was positive, and it was 30%, and it was, again, grade group 3. Note the 12 core was completely negative. Patient underwent a repeat treatment with cryoablation. As you see, his PSA was stable around 1 to 2, rose to 6.4, underwent a repeat treatment in 2020. And then he had a repeat MRI recently, and which demonstrated that he has persistent enhancement in the midline area that was retreated with cryoablation. So we discussed this with the patient in terms of potentially performing a repeat biopsy, or alternatively just following him. At the current time, we've decided to just follow him as PSA has continued to decline. And really, the question is going to be, what do we do if there's persistent disease, or just with those imaging findings alone? Here you can see his functional recovery. His urinary symptoms stayed relatively stable throughout his course of treatment. His shim did have dips immediately post-treatment that recovered at 6 months. In full disclosure, after his second ablation at 3 years, where you see his shim dropped to 7 and improved to 18 out of 25, after a second ablation, he did require erectile aids where he did not prior. So thank you, and look forward to hearing the discussion from the panel.
That's a really nice case, Arvin. Thanks so much for sharing that. That was an interesting trend on the shim. I noticed that if you go back a slide, the shim took a hit after treatment and kind of recovered. And it took another hit after the second treatment. So, it's an anterior lesion. And I always thought that anterior lesions were perfect for focal therapy because, it doesn't affect the erectile nerve. So what are your comments on that? Why do you think the shim came down after treatment? Do you see that happening?
I think a couple of things, and this is, again, this is kind of my own opinion, but I think that midline towards the apex, you can see the nerve start to swing anteriorly a little bit. And so I think apex in general is always a challenging place to treat because you have the sphincter that's going to be there. You're going to have the nerves coming in. You have also the DVC, and I'm concerned here that maybe this was a heat sink effect that caused a persistent area of enhancement. And maybe I should have really chosen an alternate modality on the salvage ablation. I got such a great response on the first treatment. That's really why I thought that that would be the best treatment for the second treatment as well.
Well, Arvin, may I have a question for you? Well, excellent.
Sure.
And I think for cryotherapy, sometimes the urethral can be a concern as well because it's a centrally locating lesion. I'm still a very beginner in the cryotherapy myself, and I found that for centrally locating lesion is a bit difficult to assess the success when we are placing a urethral warm at the same time. What do you think?
Yeah, you're absolutely right. That's another potential reason, especially closer to the apex when there's not that much tissue there and your cryoprobes are very close to it. This is actually from Jim Wysock, who's on this panel today, actually gave me some advice and said it's okay to actually clamp your warming catheter as long as you don't get a circumferential ablation. Now, I'm a little bit more careful when we're at the apex, when we're close to sphincter. Certainly, we have thermocouples in place monitoring it, but you're always, even with that happening, you're always concerned about shutting off the urethral warmer. So you're absolutely right, though. That certainly could be a reason for recurrence.
No, I agree with everyone's comments. I think that was a very nice initial response that you showed there, Arvin. How many cryoprobes did you actually use on your first treatment?
So the first treatment, I actually only used 2 because we were able to kind of flank it on either side and then freeze and let it freeze into the middle. That was our initial treatment plan. I find it because I don't freehand these needles, I actually put them through the grid. Going straight through the midline really risks injuring the urethra. However, I do think that maybe another option would be to come in at an angle, but I don't think that that would obviate the existing concerns about the DVC or the urethral warmer.
Yeah, no, certainly the DVC. I mean, the DVC could be a heat sink, but if you have enough ice, you probably would overcome that. So that's one thought. But, I think otherwise it looked like it was a very good initial effect. Obviously, some small tissues survived.
I think probably, Jim, we would have, with the size of that lesion and a 4+3, my guess is we probably would have used a couple more probes and made sure that you don't really have much to lose anteriorly. But again, I think that you got to really look very carefully at the lesion. And certainly this doesn't look that, at least initially, that apically. But I'll tell you, if we really have and an MRI is very reliable for predicting, distance to the urethra, the prostatic urethra and the apex. I think there are cases that far apical or where they're clearly approaching the urethra to be cautious about doing the ablation. We actually looked at our outcomes and we were quite surprised, Jack. We figured the same thing, that in terms of potency, we have really several hundred patients. And it didn't really matter in terms of changes in the shim, whether it was anterior versus posterior, which surprised us, a great deal. And actually what we'll do, Jim, in our series, we'll put everybody, just like we do for a radical prostatectomy, we'll put them on a prophylactic PDE5 inhibitor. You got very little to lose. And seeing this return is a sort of natural history of the sexual function that we've seen on a fair number of occasions.
And so, what to do next, Arvin?
Yeah, I was just about to ask the panel. So this is the quandary I'm in right now. If he does, if his PSA starts to rise again, certainly now remember at this point he is 78 years old. So if his PSA starts to rise again, understanding his goals of care as well. I was thinking maybe I would consider IRE as a potential treatment option. That's really all that I could potentially think. Or certainly salvage radiation if you would consider it.
Yeah, no, I think you're absolutely right. Tricky because ultimately it would depend on how much disease you detect. So what my approach would be is, if we're concerned that there's another anterior recurrence, I'd repeat the biopsy. I'd do it in a transperineal fashion. I'd saturate as much of that as I could to try to understand and map where the recurrence is. I don't see a problem with repeating a cryo up there if you do find some disease there, but IRE, I just don't have enough clinical experience with to know what the changes that you may have induced in the ultrasound signal would do to passing needles and whether or not you could accurately treat across that tissue, because it might all be fibrous tissue that doesn't transmit current that well. And I'd be interested to hear from an IRE expert on that type of situation. But I know cryo should still freeze it if you could localize and feel confident that you know where to go.
Well, Arvin, you start off with this patient has a pattern 5 Gleason score. So if you repeat the biopsy again and found Gleason 5, will you still approach with the focal therapy approach, or will you think it's not the
I don't think so. Yeah, that's a great question. I think my hand was forced a little bit for the first case, and I thought it was reasonable given the fact that we had the benefit of really significant counseling and good staging. But I think that at that point, I think it's kind of declared itself, and I would probably really push for the definitive treatment, but making sure that I outline the reasons why. I think that's the best option.
Yeah.
Well, Bernadette Greenwood is in the audience, and she's asking the panelists she says that for out-of-field recurrences in the apex, we use CBI, and they get very aggressive with a EuroKit 400. Perhaps Dr. Feller could comment, since he's here, he probably knows what kind of practice that is.
Yeah, so in particular for apex lesions, whether they're treatment naive or salvage situations, we find the the transrectal laser approach is really safe and really feasible. We can see the external urethral sphincter throughout the treatment. We can protect it with safety cursors if we need to. And with a transition zone with laser being only 1 millimeter between, completely destroyed tissue and completely viable tissue, we have, much lower risk of causing urinary incontinence with lesions in that particular location.
I would just counsel that we have multimodal ways to treat prostate cancer, right? And I really, if not necessarily in this case, but I do think when you really get to have apical lesions, whatever modality one is going to employ, I think the chances of leaving positive margins are problematic. And I think the concern in this case, probably, look, if you have a 3+4, it's a relatively low aggressive disease. Leaving a positive margin isn't the end of the world. But, you saw this guy's PSA doubling time take off before treatment. You saw it take off again. And I think this is telling you this is a bad acting tumor. I think it was perfectly reasonable to do a cryo first. It's a local recurrence. I think it's reasonable to consider because this is really maybe a treatment failure. But I think this PSA and this rapid recurrence is telling you something about this disease. And other than the fact that he's 78, which would obviously influence your treatment, I would just be, cautious about, why you have a failure. And I'd be very concerned that this is getting apical and almost anything you do from a focal approach is going to not, solve manage the disease. And this, I think, is bad disease.
Yeah, thanks, Dr. Lepor. Yeah, those are really words of wisdom, and that's what we want to hear. I mean, we want to share with the audience our experience, and perhaps that PSA doubling time is telling us something about the disease biology. And at the end of the day, we can't beat the biology, so we got to be really aware of that. That's a great discussion, really nice case, Arvin. In the interest of time, I'm going to move on to the next case. The next case is by Dr. John Feller. Dr. Feller, please take it away.
Great, thank you, Jack, and thank you for the invitation to share in this venue. See if I can advance the slides here. I think somebody's got to share control here to me. So actually, this discussion is really a nice segue for the case that I'm going to share with you, which is essentially a focal therapy case using outpatient transrectal laser focal therapy in a high-risk patient. So our patient's actually a 78-year-old male who's a radiation oncologist, over a 30-year career specifically treating prostate cancer, had a family history of prostate cancer and an uncle. Serum PSA had increased to 5.8, corrected for finasteride therapy. He was undergoing testosterone replacement therapy and was also on medication for BPH with lower urinary tract symptoms. His MRI showed a PIRADS-5 lesion in the left peripheral zone at the base, mid-gland, and apex levels that measured over 2.5 cm in its long axis. He had a targeted biopsy, and you can see that all of the cores were positive, with 50 to 70% of the cores involved with tumor using an in-bore biopsy type of approach. And this was a grade group 5, high-risk cancer, so Gleason score 4+5, with about 10% of the tumor demonstrating Gleason grade 5 pattern. The staging workup at this time 3 years ago, we didn't yet have the PSMA available, which is what we've shifted to now. But on the Axeman scan, there was no evidence of extension to local nodes or distant metastatic disease. So he was an N0, M0. We're risk stratifying these patients. One of the tools we're using is a biomarker that's circulating tumor cell biomarker with the BioSep test. We're really interested not only in using this for risk stratifying patients before focal therapy, but also looking to whether or not this may be a reasonable definition of minimal residual disease, or a replacement for a definition of biochemical recurrence. in patients that have been either successfully or unsuccessfully treated with focal therapy. But you can see in our patient, we've got 11 cytokeratin negative circulating tumor cells and 4 cytokeratin positive circulating tumor cells based on the liquid biopsy test. These are images from the MR thermometry and the placement of the laser applicator, which again was done in an outpatient setting transrectally. No general anesthesia. This is just using a periprosthetic nerve block and conscious sedation. You can see on the immediate contrast enhanced post-procedure images, we attained our goal, which is basically to get rid of the MRI abnormality, the Pyrites 5 lesion, plus a 1 centimeter margin surrounding it. On the 6-month post-laser multiparametric MRI, we see evidence of some scar tissue fibrosis and focal volume loss, but there was no evidence of residual or recurrent disease at the treatment site and no evidence of out-of-field recurrence. You can see the PSA nadir down to 0.11 with a PSA density of only 0.003, corrected for finasteride therapy, 0.006. So it came way down. We biopsy the treatment site in all of our focal therapy patients at 6 months to a year, and you can see that the sweep biopsy done at the treatment site with an in-bore biopsy showed no evidence of in-field residual or recurrent disease. And on the MRI, there was no evidence of out-of-field recurrence. 3 years later, in this high-risk patient whose life expectancy originally was less than 10 years, and he's now 81 years old, you can see that his MRI remains negative, and you can see that we were able to get him off of his finasteride and his Flomax therapy because of the fortuitous decrease in prostate gland volume due to the treatment of the cancer that improved his urinary tract symptoms from the BPH. And you can see his PSA density also has remained stable at 0.006 3 years out. So we have very nice oncology control and also a PSA density that's rock stable. In terms of functional outcomes, pre-laser compared to 6 months and 1 year post-laser, you can see that the urinary symptoms actually improved a little bit following the laser focal therapy. You can see that no significant erectile dysfunction developed during this time frame, and also the mental health PROM, the PHQ-9, really favorable in this type of a focal therapy paradigm. So to summarize, I share this case because we've got a treatment-naive patient whose life expectancy originally was less than 10 years. To think about, the potential role for focal therapy in older patients with high-risk disease to avoid the side effects of whole gland therapy in that age group, especially just putting them on androgen deprivation therapy at that age. And also that we were able to, get rid of the finasteride and Flomax therapy for a symptomatic BPH. So really good functional outcome. At 3 years, we've got good oncology control. And just, to really kind of challenge the thought in treatment-naive men, whether or not there may be a role for focal therapy to treat high-risk disease, preventing, the problems of local regional disease in that age group, potentially, pushing out the development of metastatic disease and avoiding the side effects of things like androgen deprivation therapy in this age group.
Thanks, Dr. Feller. That was really a very beautiful case, and congratulations on treating this 78-year-old gentleman, former radiologist, very successfully with focal therapy. Now, just some feedback from the poll, and we have 54 participants now in the who are with us in the tumor board. 12% said that they don't use focal therapy presently. 18% are thinking of starting a program. 12% have just started using it, and 59% routinely use focal therapy in their practice. So that's the audience we are having today. I guess a question for the panel. This was a Pyrites 5 lesion, and it turned out to be grade group 5. So is there a maximum lesion size that you would treat? Is there a maximum Gleason score for treatment? Anyone in the panel, I guess?
Well, I think in general, for focal therapy, we are saying the sweet spot would be the intermediate risk disease. preferably 3+4 or sometimes 4+3. But I think here Dr. Feller has demonstrated beautifully what we might do with focal therapy to expand that concept. Because I do agree to some extent, while we are trying to use focal therapy to eradicate the disease in the majority of patients, for some of them, we can use it as kind of, well, this may be sensitive to palliate the disease, but we would try to postpone the side effect of radical treatment as much as possible. And I think here Dr. Feller has demonstrated beautifully. To some extent, focal therapy is not just to provide another way to provide radical treatment. It's also an alternative concept to use it as a way to palliate the immediate threat of the disease to the patient. And let's see what other faculties think about this concept. I do agree it's a good way to do it.
And look, I think this is a great case, but remember, when you treat Gleason 9, this is a very unique Gleason 9. You're not going to find that many Gleason 9s that are so well defined. And it's not as much, Jack, as the size, it's where the tumor is located. You couldn't find a better spot to have a Gleason 9 tumor you know, I'm just a bit surprised. First of all, it's hard to find a 78-year-old. I'm surprised that you didn't even tickle that shim when you ablated this lesion, which looks pretty close to where I recall those nerves to reside. I'll make two quick comments, and one is on the IPSS. You know, when Jim and I actually stratified based upon symptom severity, right? So if you look at the overall group, most men don't have bothersome symptoms, so you can't improve it. But if you take that group that has, you know, severe symptoms, which is an IPSS over 18, and you do focal therapy, you're going to see dramatic improvement in that subset. And then finally, and I don't know if you want to get into this debate now, but when should you do a biopsy? Now, here's what I would say we've sort of evolved at NYU. If you're starting a program, you should do imaging and biopsies early on as a way of gauging your technique. So for Jim and I, at 6 months, we biopsied everybody, and our positive biopsy rate is 2%. So we no longer biopsy, because at 6 months, you're really dealing with infield recurrence, which I think is your selection and your technique. And if you have decent technique, and if you have good selection, then a 6 month to 1 year biopsy, I think, is a waste of time. But you should only embrace that once you have experience with focal therapy and the confidence in your technique. I believe once you get, like in this case, to 2 years, you're going to start to wonder if you have some microscopic infield recurrence. You may begin to see that in 2 years, especially with the Gleason 9, or you may actually have time for disease that was not identifiable. It will manifest. So we're now biopsying everybody at 2 years. And I have this debate with Emberton. I think the only way you can say you don't need to biopsy if you prove you don't have to. And so at 2 years right now for us is the sweet spot. And so what we would do is biopsy this fella, do another MRI and a biopsy at 2 years. But I think, John, this is a perfect case for someone who's made his life out of taking out prostates. I think at this age, you shouldn't be, you shouldn't, just because it's a Gleason 9, abandon focal therapy. I think this is a perfect case for it.
Fantastic. And you alluded to that, Dr. Lepor. Arvin, how about in your practice? Do you always do post-treatment biopsies? Do you biopsy just the treated area, or do you biopsy the untreated area as well? And how much do you biopsy that?
Yeah, so at 6 months, I will biopsy. I'll do a target-only biopsy, and then I will add a 12-core 4-cause. So, for example, if there is a rising PSA, I would add a 12-core. But generally, these patients have had a recent biopsy, usually within 2 to 3 months of their treatment. So repeating a 12-core, I don't feel is necessary. But I will perform a 12-core if required otherwise. And I will say conceptually, I think I do agree with Dr. Lepor and Dr. Yee in that, in terms of looking at other indications for focal therapy, we already struggle with this patient population when focal therapy did not exist. Really a balance between giving them the benefit of the doubt regarding their life expectancy and really preventing the harms of disease progression. And the NCCN guidelines do say that, for men with Gleason 7 or above with a life expectancy of less than 5 years, that radiation should be the treatment of choice, but perhaps focal ablation should be part of that rubric.
Right. Jim, I'm not going to ask you about biopsy since you practice with Dr. Lepor, but for something that is something like a grade group 5, do you think there's any role for adjuvant therapies at this time together with focal therapy?
Well, I don't think there's any clear role at this point, but I think we would need to look at trials and, future data to help support that concept. I mean, interestingly, this patient was on finasteride. You could consider finasteride almost a mild hormonal manipulation to some degree. You saw we had to correct for his PSA density and all of the evaluation. So what role that has played in affecting the malignancy is unclear. So I don't know yet, I think is the short answer, but I will make one comment on biopsies. One thing that I do use, and I think this is kind of helpful, although I think it's early to know, is one of the things that we'll touch on, and I think it was touched on in this case, is what's the margin of the treatment, right? Margin is a critical component here. The imaging doesn't tell us the exact extent of the disease to be treated. So one thing I've added into my paradigm, which I've been doing for a number of years now, is prior to treatment, I do a pre-treatment planning biopsy in a transperineal fashion. I map out the area of the lesion and what I would consider the necessary margin to be. And I have found patients that will have disease that extends in directions that you wouldn't have automatically linearly calculated off of your imaging. So it's not a perfect sphere, so to speak, your margin. And so that can be very helpful. And so that's a biopsy technique that I think can help in selecting patients. And for the other aspect of that is by doing it in a transperineal approach, when I'm going to use a transperineal treatment approach, which is what I use for cryo, it also helps me sort of align the treatment along with the biopsy cores. And it gives you an idea of how far, each direction that you would want to plan out your treatment. And so there is a lot of role for biopsy in these men. And I agree 100% that we need to follow them carefully, and that biopsying them early and detecting recurrences early gives us the best opportunity to salvage those treatment. I think Arvin's case demonstrates that nicely. And I think that's a very important aspect of where we're at with focal therapy today. And so where adjuvant therapies could play into it would be part of the future, but it would have to be in a very rigid paradigm in terms of checking our disease control efficacy.
Yep, thanks. That was a very, very informative take on it. And, for the audience, there's no cookie cutter approach to the margins. I mean, you hear about how Jim is customizing his margins based on his biopsy. So it's really a customized treatment for each patient. Just one last question on this case to Dr. Feller, since you're our radiologist on the panel today. Do you think there's a role in PET for, besides staging, localizing the tumor within the prostate? Do you think that's going to contribute to MRI in any way?
Yeah, I really think it will. As we all know, the MRI underestimates the size of the tumor by up to 7 millimeters in any one direction and up to 30%, volume-wise. So it may help potentially with treatment planning. Certainly when you have post-therapy changes that we deal with on the follow-up MRIs, it may help with local recurrences. And I think we've certainly taken a step forward transitioning to PYLARIFY and the PSMA type of solution as an improvement, even compared to Axemin. But we need to do a better job of throwing away the old bad stuff. I mean, the idea that a nuclear medicine bone scan and a CT of the abdomen and pelvis provides any such information compared to these new tools. We need to sort of put the old stuff away to make room for the payers to support, where this is going.
But Jack, one comment, when you look at this case and you plan out your margin, you have to realize you have nothing to lose by coming across the midline. You have nothing to lose by going more anterior, and you better extend this outside of the capsule. So I think when we talk about margin, you really have to say, well, what are the functional limitations, right? And so especially in this case, I don't think you need to be that precise. I put a couple probes if I'm doing this cryo anterior just to help bring the ice down. I probably cross the midline. So I bet if I was doing this case with a cryo, I'd be using, and probably Jim as well, at least 5 probes because we got nothing to lose and we got a high risk patient. And this is sitting right in a spot that's perfect to get a good margin, I think.
Yeah, not only that, you need a confluent treatment volume, right? You have to capture all of the index lesion within the, and I think that's where the critical number of, energy density that you can achieve with the number of probes is very, very important. That is something, we published on 3-dimensional tumor modeling, and then also employing 3-dimensional cryoprobe modeling. What's interesting is the different energy modalities will have different modeling techniques. For example, with the laser, what we're seeing here, obviously that has a very different 3-dimensional treatment volume, and you have to make sure that that kill volume is going to include your tumor plus margin. And how you achieve that is very important with each treatment modality and how you model it. I know by looking at the IRE or the HIFU approaches, it's very different from cryo and maybe very different from laser. So it's just something that each user, as you become familiar with your technology, is going to have to pay very close attention to how to achieve a 3-dimensional kill volume that encompasses your index lesion.
Great. Great points, everyone. In the interest of time, I'm going to move on to the next case. I think the next case is Jim. That's your case, Dr. Wysock. Dr. Wysock, please take it away.
Okay, so this is a case that I wanted to present to just sort of that one of the themes of the talks was essentially patient selection and salvage approaches. So I called this margins and monitoring, and basically it's very similar to some of the cases we've already talked about. A man in the 70s, he initially presented in 2016 with a PSA 5.6. He has a family history that's significant. His brother died from metastatic prostate cancer, but otherwise he's very healthy and he is sexually active. The PSA had risen, as I showed on the last slide, but we, prompted us to get an MRI of his prostate, which shows 2 lesions on the right side of the prostate. One is about 4 by 4.5 millimeters, and the other is right at 7 by 3, and they're sort of mid-gland and anterolateral, and they're not large lesions by any means, but they were considered PIRADS 4. So then he underwent prostate biopsy, which demonstrated only in the mid-gland, which is the top image there, some Gleason grade group 2 in a small amount, 2.5 millimeters with pattern 4 was 10%. I sought out oncotype on him, and actually the oncotype score came back as not enough tissue to give us a gene expression profile on that. So ultimately, with a strong interest in preserving his sexual function as his primary goal here, he underwent a partial gland ablation with HIFU back in June of 2016. We did a 2-zone treatment, and we used a 5 millimeter margin. Now, this was very early in our treatment experience with HIFU, and I could show you here some of his post-ablation images, and they do completely encompass the lesion of interest. Remember that right anterolateral lesion that I showed you was negative on targeted biopsy. So we were happy with that. He did show some PSA decline after HIFU. He had an MRI at 6 months and a biopsy at 6 months. The MRI was read as negative, but the biopsy did show some grade group 2. It was in the lateral margin of the ablation zone. And there was also some Gleason grade group 1 in the 6 cores that were on the ipsilateral side of his prostate. So importantly, it looks like early on, I'm identifying here that we probably had a margin failure, okay? So we were seeing some grade group 2, actually more than we saw in his diagnostic biopsy, right on the lateral edge of his treatment. So he elected to do a repeat ablation. And on this repeat HIFU ablation, we did a 3-zone treatment. We've taken some of what we had learned about trying to improve our energy density. We used the 3-6 sequence on the HIFU machine, and we used the centimeter margin. And here's some imaging that shows you what that looks like. So I think one of the key take-homes there is that margin really does matter. What he reported over time was that he did lose his ejaculation volume. And for him, this was a kind of a pretty significant impact on his overall function. He was disappointed about that. He still had erectile function, but had lost ejaculation function. I think that's something interesting that as we continue to do partial gland ablation and organ sparing treatments to the prostate, what it can do to sexual function is not just erections. And so that's something important to discuss and for our field to really explore. But what you can see here at 6 and 24 months after that second ablation, his imaging was negative. He did develop some image findings in the contralateral prostate, but all of these were negative. And now as we start to see, the PSA after that second ablation came down very nicely, but there was an uptrend over time. And that time is over about 3 years. And then most recently, he had some periodic episodes of prostatitis, and his PSA started to climb significantly and got back up to 4.5, which is after about 4.5 years from his ablation. So I went ahead and repeated a biopsy at this point for cause, and we found that on his right side of his prostate, near the ablation zone, basically right there in those two transperineal zones, there was some grade group 2, 3.5 millimeters, and then some grade group 1. I took some specific ablation zone biopsies there. Those were negative, but here is a late, essentially a late for our series failure of the treatment zone. And I think it highlights that, you have to keep monitoring these patients carefully. And I think by allowing me to find that early enough, he went for a salvage cryo to that site. We just did this earlier this month, 2 cryo probes because his prostate's pretty small on that side now. 2 freeze thaw cycles. He did very well postoperatively, and we achieved some very good temperature margins all around. I did maintain no freezing into his right neurovascular bundle because I felt like this disease was pretty much mid-gland, and so far we'll see how he does. But I think that was my approach there, was to try to highlight how important it is to keep monitoring these patients.
Thanks, Jim. That was a beautiful case, and you're still saving the case 4 years later. So you've really managed to salvage him now. So just to clarify, do you think that positive biopsy at 4 years later, that recurrence, is it an infield recurrence? Is it in the treatment zone, or do you think it's on the margin or something like that?
Well, look, it's impossible to really know, but if you look at this axial view of where those cores were positive, that was right in the initial treatment zone. What I think is at work here is potentially a lack of confluent treatment in the treatment zone with the HIFU at the outset. Even with a really good ablation, we've knocked down the tissue volume and the cancer volume so significantly. The PSA had that really pronounced response, as I showed here. And then when you start to see that PSA rising again, and I think this is something we all need to explore, we probably will need to pool our data to understand this, is what is a PSA velocity after an ablation to an index lesion that you should consider a warning sign. I think this graph kind of highlights it. There was something going on in that guy's prostate, and it was clearly there's some cancer in that treatment zone. Do I think that my initial treatment looked good? Yes, by all of our measures, but clearly it wasn't as confluent and as effective as I thought it should be. And, energy modalities may matter for that.
Dr. Wysock, I have a question for you. And I think you have presented a case beautifully, how focal therapy can salvage even in moment of so-called failure. For this patient, he has 2 HIFU, and the 3rd time you did cryo. So do you think it's because of the previous 2-time HIFU and it fell in the end, so you chose cryo, or it's because of the location of this recurrence that prompted you to choose cryo in the 3rd occasion?
So the reality is that the HIFU would be a good option here even still. His gland is small. You could HIFU into this, but there's one problem. The ultrasound signal demonstrates a lot of dystrophic calcification after 2 HIFUs there. I very much worry about putting HIFU into the calcification, and I think it would cause a lot of reflection of the signal, and cryo does not have that limitation. So I thought cryo would salvage. Now, if that was a clean looking ultrasound view and I was confident I could put that energy, there's no reason why HIFU wouldn't be able to be delivered to this particular anatomical location.
Right.
I just have a lot of concerns about the confluence that you get with HIFU. I mean, with the cryo, you map out your probe distances. You see how you deliver the energy. You don't see the popcorn. You sometimes really have to turn down the energy. And that worries me as we get to some of these more automated systems where you just sort of push the button, go out and have a drink and come back. Actually, I've given up HIFU because Jim is so much smarter and so much technically more adept that I just feel I can't deal with all of these buttons and everything. So if there is a case for HIFU, I just send it to Jim. I know my limitations, but I just worry more about the confluence. And if you just have one of those energy pulses, that 10/3, right, millimeter pulse, and it doesn't hit. And again, I just worry as you get these automated systems, because you watch Jim doing this, he's upping the energy, he's slowing it down, he's retreating. And my big concern is that if you automate this, it's going to be an issue. And let me just say one other thing about, you must talk to patients about ejaculation. And I am surprised how small volume ablations lead to almost an ejaculation. And most of these patients are driven to focal therapy because not just their erection, but the whole process. And if you don't tell them about ejaculatory dysfunction, you're going to be having, no disease, erections, continence, and a patient that's pretty angry at you.
And thank you, Dr. Lepor. I have a question for the panel and for you specifically. We certainly don't necessarily want to hold focal therapy to a lower standard, but I think for those of us who have a long enough longitudinal experience, we're starting to see that some of these cases, or some of these, how we conventionally think about prostate cancer may be different. Maybe with focal therapy, it is kind of a relapsing, remitting cause. Is that a reasonable way to think about it? I certainly do counsel men that you may need more than one ablative treatment.
Let me just make one comment. When you have on biopsy, the way they validated the Gleason grade group, if you have a Gleason grade group 2, you have a 25% chance of recurring after a radical. If you have a 4+3, you have a 50%. So, Arvin, you presented a case of a 4+3. You could do a radical and have a 50% chance that will have a recurrence. So the fact that we have recurrences after focal therapy isn't an indictment of the treatment necessarily, probably an indictment in many ways of the disease.
Yeah, that's a great point, Dr. Lepor. And you've always been very big on disease biology, and I do believe that that's the way we should go to select our treatment. Now, this gentleman has a pretty strong family history of prostate cancer. Does that factor into how you would select treatment for this patient?
So, I would tell you with a family history and a mortality at 60, what I might do, I would probably do genetic testing. And if this patient had a mutation, I would stay away from focal therapy, because I think you just have a greater concern about the prostate that you're leaving. So that might be the thing. He's older, so you're less concerned. His brother had that mortality young, but I might consider a genetic testing on him according to guidelines. And if he does have a mutation, really think twice, unless he's 79, like the really great case that John presented, right? I'd be a little bit more skeptical about focal.
And for genetic testing, you would be doing looking for BRCA and
correct. Correct.
Right.
Yep.
Okay. Very cool. And I think there were some, since we're on the topic of biomarkers, there were some questions in the chat. Bernadette Greenwood is asking, does anyone use the Cipher score to guide how you select these patients? And, I think Jim mentioned in this case, you tried to do oncotype, but that wasn't successful. So what does the panel think? I'm just going to go around to find out who uses these markers. John, do you use these?
Yeah, so we routinely use them. I'll just give kind of one interesting fact. In our 12-year cohort with laser focal therapy that we've been using the Decipher for biopsy solution, about 15% of our Gleason 3+3 or grade group 1 patients actually have unstable genomics. Their Decipher for biopsy is intermediate risk or even high risk. And when we follow these patients over 12 years, these are patients actually who, even though they're grade group 1 disease, they're these whack-a-mole patients that have, field cancerization going on. They're more likely to develop a local recurrence in field or an out of field recurrence. So their behavior and natural history actually tracks more with the tissue-based genomics and the Decipher for biopsy in some of these patients than it does with the histology. So we think putting them together, the histology plus tissue-based genomics, liquid biopsy, it helps to mitigate, number one, the blind spots of each one of these tests individually. And number two, this is how you mitigate the one word that describes this disease best, which is heterogeneity. You can't just rely on any one of these individual biomarkers or even the advanced imaging, but putting them together in a sober, thoughtful way can help to, even mitigate the heterogeneity of the disease.
Great point. Thanks. How about the rest of you? Do you use that routinely? Jim, would you use Decipher or Oncotype to decide whether they get focal therapy or not?
I don't use it as an exact determinant, but I agree that it is a helpful piece of information. I get the Oncotype primarily on intermediate risk prostate cancer, some of the low risk, and use that to sort of risk stratify a little bit further. I find that the Oncotype has a nice way of giving you a score and relating it to the average score for that particular pathology. I think that can help in discussions with patients. For example, if I were to have someone who looked like a Gleason grade group 2 on their biopsy and their Oncotype came back with a score of 50 and it was considered very high risk, I would counsel that patient that they're probably at higher risk. I don't know if it ultimately influences me to not pursue a focal ablation, but I do use this. I think time will tell. I think we need to really look at this over time and see if it can help us. I still have some questions, and I don't have a particular preference of Decipher versus Oncotype. I just have much more clinical experience with Oncotype.
Okay, so let's, in the interest of time, we're probably going to move on to the last case, and we can leave any other comments for the end of that. So our last one is by Dr. Samuel Yee. Did we miss the tumor? Samuel, please.
Well, thank you, Jack, and thanks for the panel's excellent discussion beforehand. And here I'm just trying to share a case early in my HIFU series where the diagnosis of the tumor and also patient selection were meant to be quite important for focal therapy. This is a 78-year-old gentleman with good past health presenting with a PSA 7.1. IEF is not very good during his presentation. And at that time, and I'm sure in some centers in the world, we are still not doing MRI first. And in some patients, when they presented with an elevated PSA, they would come with a systematic biopsy results, and then we'll order an MRI. So here for 42-gram prostate, he actually went through quite an extensive systematic biopsy. We did it in a transperineal manner, and we found there were 2 positive core in the left postural peripheral zone with Gleason 4+3. And then we ordered an MRI, and we found the left peripheral zone 5mm tumor probably corresponded to the Pirates 4 lesion that we observed on the MRI on the left-hand side of this slide. But at the same time, we saw there was a Pirates 3 lesion at the right transitional zone. Because we did the biopsy in a transperineal manner, so at that moment, I thought, if it is really a 12mm Pirates 3 lesion, it was quite difficult to miss it if we did a transperineal biopsy. So I believe it was not a tumor on this Pirates 3 lesion, and we proceeded with HIFU focal therapy. And we focused on the left peripheral zone, and we did a quadrant ablation. And after the ablation, we successfully covered the zone of interest, and this is a post-HIFU 1-week MRI where we used for the assessment of ablation zone, but it was not meant to be a routine assessment, and it's not necessary for every case. Unfortunately, after the ablation, we did not see a very satisfactory drop in PSA. So, in the time span of almost 12 months, the PSA is still not dropping. So we did another MRI. Usually for my case, I would at least have a 6 months and a 12-month MRI after my initial treatment. The left peripheral zone treatment zone was atrophic. The treatment zone was very successful, but the transitional zone lesion was persistently there with the size of 12mm like before. So we did a target fusion biopsy, and 18 core systematic biopsy, we found that the right transitional zone lesion was in fact ISUP grade group 3 and 4 prostate cancer. So for this patient, the development of his story is that we have a metastatic workup. He did not have any metastasis on PSMA scan, and the patient subsequently went for radiotherapy because of the presence of a Gleason 4 pattern on the follow-up biopsy. So I think for this case, first of all, even for very extensive transperineal biopsy, T-zone apical lesion could still be missed. And so I learned that for focal therapy preparation, probably it's best to have fusion biopsy, entire biopsy, to have the best patient preparation. And I'll see how the faculty thinks of whether this patient can benefit from another focal therapy, or because of the Gleason score, you also go for a more radical treatment like radiotherapy or radical prostatectomy.
Thanks, Sam. That was a great case. I'm just going to move back to the scan to show that TZ tumor, which was obviously out of your treatment zone. Yeah, I guess it's a great question. Would anybody try ablation again? For me, I would be quite concerned. I use primarily cryo, and this is kind of like peri-urethral. So I guess a question for all the other more experienced cryo operators, is that possible?
Look, he's 78, so that factors in, right? And so I think you can ablate that lesion with almost impunity. I would say that what I tell patients once they fail a focal therapy, that I'm willing to do their radical after one failed focal. I'm not willing to do it after 2. So that if we do another ablation and they then fail, they bought themselves salvage radiation down the road. Now, for most, that's not a disqualifier, but that was a 3+4. He's 78. I wouldn't have any objection to re-ablate him. Certainly, the radiation is a very reasonable option, and so I'd have no qualms about. But I think the lesson learned is that to probably target that ahead of time. The question is, if you had 2 lesions at that point, would you not have done a focal? I probably wouldn't have done a focal if I knew that was positive. But having done a focal, and it looks like a very successful focal, I would probably go ahead and do it on the second side.
Well, thank you.
I agree, Sam. I think that's a good case to highlight the concept of pre-biopsy MRI. I think that's really the sea change that occurred for many of us to say, look, this makes sense to do a focal treatment, because when you really feel you have one spot, what happened here is if you look back at the early T2 image that you had after the initial biopsy, you can see there is in that region a small area that that they read as Pyrites 3, but it looks like it's enlarged a little bit over this time. So I think critical concept here for people interested in focal is that the imaging is really critical for helping us identify people with a unifocal disease at the time of treatment, and putting them through a targeted biopsy to confirm that. And those are going to be our ideal candidates, especially if you're starting out.
Right. May I direct the question to Dr. Lepor, because Jack initially mentioned is a lesion quite near to the urethra. But in fact, it's not near the apex as well. So when you try to do a cryo, will you use urethral warmer, or you just do the cryo without a warmer in this case?
A lot depends. Sometimes once you put that catheter in, where you think the urethra is in a very different spot. And sometimes you can torque the catheter up a little bit and sort of, or the warmer, as well. So a lot of times we put the catheter in the first time, before the warmer goes in. And I would bet you that'll be a distance away. And it's a 3+4. So probably for him, if you left a few cells, it's probably not the end of the end of the line. But if it's definitely encroaching on the urethra, then then I don't necessarily think debulking is where we should be heading.
So Derek Lomas is asking, will any of you work off an external provider fusion biopsy, or will you always repeat your own prior to focal?
I tend to see that a lot outside biopsies, and it really depends on my knowledge of that, of that person, and I feel whether or not I feel that I'm confident that they have good imaging and they have good fusion. Certainly, if I have access to the biopsy images and core tracking, that's even more helpful, because I can, to a certain degree, verify registration and to see if there's any overlap between positive systematic cause and the target. But I err on the side of rebiopsying, but that's a difficult conversation to have with a patient.
The problem I would say is not if it's concordant with a lesion, but let's say a guy has a 5mm PIRADS4 contralaterally and that's negative. And we know there's a reasonable chance of having a false negative even when experts like us do a biopsy. So where I would have a challenge is if they've had a biopsy and contralateral, there's a PIRADS4 that's negative, I would probably rebiopsy that. The question is, would I rebiopsy my own negative biopsy? We know if you have a PIRADS4, and if you follow that a year later, that's negative, about half of them go away. And overall, about 20% are true false negatives in our NYU experience. So I would say if it came from Memorial, I would definitely rebiopsy it, right? But if it came from Jim, I wouldn't.
Okay, so great points. And I think we could go on with this discussion for a long time, but I'm always mindful of the time, and now we've approached the end of our allotted hour. So I'm just going to call that a close to the session. We had an excellent discussion covering the points of treating limited volume high-grade cancer with focal therapy. We had 3 cases of choosing a salvage modality for recurrence after focal therapy, and we had some really excellent points on when to do a repeat focal therapy or when to fall back on whole gland salvage. So I'd like to really thank the faculty panel for your wonderful discussion and the audience for being here to learn and share these lessons with us. And thank you all, the audience, for all your comments and interaction. Now, this is the second webinar in our series, along with the first webinar we did in August last year. These are all available online at the Focal Therapy Society website, which is at www.focaltherapy.org. If you haven't joined as a member, please join us. These webinars are free to air on the website. So please, if you have anyone who is interested in focal therapy, have them view these webinars again. We are planning for our next iteration in May this year, 2022. So please look out for our next email blast and join us again. We are always looking to improve. So please do take a moment to fill out the evaluation form before you log out of the Zoom meeting. Again, on behalf of the Focal Therapy Society, I thank you for your participation, and I wish you a great day or evening ahead. Thank you so much.